Welcome to Lexturio Podcast. Here we break down complex medical concepts into clear and concise discussions that reinforce your understanding.
And today we're jumping into a really important respiratory condition, bronchiectasis. It sounds complex, but at its core, it's about a destructive cycle in the lungs.
Exactly. Think of it as a chronic disease where the airways, the bronchi, become permanently damaged and distorted. They get wider, dilated, and just don't work properly anymore.
So it's not a temporary inflammation, this is permanent damage we're talking about?
That's the key word, permanent. And this damage kicks off what I call the vicious cycle. It's a continuous loop of inflammation, which leads to bronchial damage and dilation.
Okay, so the airways are damaged and widened. What happens next?
Well, because they're misshapen, they can't clear out mucus and secretions effectively, so that stuff just sits there.
And I'm guessing stagnant mucus is a perfect breeding ground for infections?
You got it. Recurrent infections. And those infections cause more inflammation and more damage, which impairs clearance even further, leading to, well, more infections. The cycle just feeds itself.
Wow, that sounds relentless. What starts this whole destructive process? Is it just one thing?
That's the tricky part. In most cases, it's actually idiopathic, meaning we don't know the exact cause. But there's a long list of potential triggers.
Like what? Give me the greatest hits.
Sure. Primary infections are a big one. Think of severe bacterial pneumonia from things like Klebsiella or Pseudomonas. Even viral infections from childhood, like measles or pertussis, can set the stage for this later in life.
Interesting. So a bad infection can leave behind this lasting damage. What about non-infectious causes?
Absolutely. You can have bronchial obstruction, maybe from an endobronchial tumor, or even an inhaled foreign body. Then there are congenital disorders, which are huge. Cystic fibrosis is probably the most well-known cause of bronchiectasis.
Right, I've heard that connection before. And the list also mentioned things like primary ciliary dyskinesia and even autoimmune diseases?
Yes, exactly. Conditions like rheumatoid arthritis or Sjogren syndrome can contribute. The body's own immune system can be part of the problem, driving that initial inflammation.
It's amazing how interconnected everything is. So if a patient has this, what are they experiencing? How does it present clinically?
It's usually a very slow, progressive disease, developing over years. The hallmark symptoms are a chronic cough and daily sputum production. And we're not talking about clear mucus. It's often thick, mucopurulent.
So a persistent, productive cough. Anything else?
Dyspnea or shortness of breath is common. Sometimes pleuritic chest pain, wheezing, and even hemoptysis, coughing up blood, can occur because of the airway damage.
And then they have these flare-ups? The exacerbations?
Yes. During an acute exacerbation, everything gets worse. The amount of sputum increases, it might become more purulent or have a foul odor. They'll feel more fatigued, more breathless, and might run a low-grade fever.
Okay, so we have the symptoms. How do you actually diagnose it? How can you be sure it's bronchiectasis and not, say, COPD or severe asthma?
That's a fantastic question, because the symptoms can overlap. The definitive diagnosis comes from imaging. A chest X-ray might show some signs, like thickened airway walls, but it can be normal in up to 50% of cases.
So the X-ray can miss it? What's the better test?
The gold standard is the high-resolution CT scan, or HRCT. It's much more sensitive and specific. It gives you this incredibly detailed view of the airways.
And what are you looking for on that HRCT? What are the telltale signs?
There are some classic findings. One is seeing the airway dilation directly. You might see what are called tram lines, where you have these parallel lines from thickened bronchial walls, looking like tiny railroad tracks.
Tram lines. I like that. It's very descriptive.
Another classic is the signet ring sign. In a cross-section, you see the dilated bronchus right next to its accompanying smaller pulmonary artery. It looks just like a ring with a jewel on it.
Wow, that's a powerful visual. So you're literally seeing the abnormally wide airways. You also see things like a lack of bronchial tapering, right? Airways that just don't get narrower like they should.
Precisely. And you can sometimes see the tree and bud pattern, which represents airways filled with mucus plugs. The HRCT really tells the whole story of the structural damage, which is what separates it from something like asthma, where the obstruction is reversible and the structure is intact.
That makes so much sense. So once you have the diagnosis, how do you manage it? You said it's permanent, so it's not about a cure, right?
Correct. Management is all about breaking that vicious cycle we talked about. The goals are to improve symptoms, reduce exacerbations, and manage any underlying condition.
So how do you break the cycle? What are the main strategies?
It's a multi-pronged attack. First, you have to improve the clearance of that mucus. This involves things like chest physiotherapy and deep breathing maneuvers to physically move the secretions out.
So airway clearance is number one. What's next?
Next is relieving any airway obstruction. This is where bronchodilators, like beta agonists, come in, similar to what you'd use in asthma or COPD, to help open things up.
Okay, clear the gunk, open the pipes. What about the infection part of the cycle?
Antibiotics. They are crucial, especially during those acute exacerbations. Sometimes empiric antibiotics are used, but ideally, you want to tailor the treatment to whatever bacteria grows from a sputum culture.
And of course, managing the underlying cause if you can find one, like treating an immunodeficiency or managing an autoimmune disease.
Exactly. And preventative care is huge. Vaccinations for the flu and pneumococcal pneumonia are essential. And of course, smoking cessation counseling is a must.
It really is a comprehensive management plan. It has to be, to fight that relentless cycle.
It does. To sum it all up, remember bronchiectasis as a disease of permanent bronchial dilation. It's driven by that vicious cycle of inflammation, damage, poor clearance, and recurrent infection. The diagnosis is sealed with an HRCT showing classic signs like tram lines or the signet ring sign.
And management is all about breaking the cycle. Airway clearance, bronchodilators, and antibiotics.
You've nailed it. It's a chronic condition, but with good management, we can significantly improve a patient's quality of life. Thanks for tuning in to the Lecturio podcast, and we'll see you next time.
Thank you for tuning in. Keep exploring Lecturio's features to strengthen your knowledge and master key medical concepts. See you in the next episode.